So today we are starting a new chapter, that is menopause. Menopause is simply defined as the cessation of menstrual cycle, and a woman who had experienced 12 months of amenorrhea without any pathological or physiological cause is known as menopause. Menopause refers to the time period around the menopause, and it is the time applied from the onset of ovarian dysfunction until 1 year since the last menstrual period. And post-menopause refers to the 1 year since the last menstrual period. And the menopause usually occur at a median age of 51 to 52 years. Now let's talk about the risk factors that can lead to a menopause. First one is the iatrogenic causes. The iatrogenic causes include bilateral oophorectomy, which is the removal of both the ovaries, and the constant high doses of GnRH. So the continuous dosing of GnRH, they desensitize the FSH and LH receptors and the anterior pituitary, and hence they decrease the release of FSH and LH and will lead to the amenorrhea. And the constant high doses of GnRH are used in various gynecological conditions like endometriosis, but they may also cause menopause. Second one is the premature ovarian failure. Premature ovarian failure is the menopause before the age of 40 years, and it is usually associated with elevated level of FSH and LH because there is decrease in the level of estrogen, which causes compensatory increase in the FSH and LH. And premature ovarian failure, the biological appearance of the ovary are those of the postmenopausal ovary. And the causes of premature ovarian failure include primary causes and secondary causes. The primary causes include chromosomal anomalies like Turner syndrome, enzyme deficiencies like galactosemia, 17 alpha hydroxylase deficiency, which are congenital adrenal hyperplasia, certain autoimmune diseases like hypothyroidism, Addison disease, and myasthenia gravis. All of these can cause premature ovarian failure. The secondary causes of premature ovarian failure include chemotherapy, exposure to radiation, and infection with the Mycobacterium, varicella, mumps, and the malaria. Third one is the resistant ovary syndrome. It may also causes menopause. And resistant ovary syndrome, there are viable and abundant follicles in the ovaries, but they are resistant to the FSH and LH. Therefore, it is usually associated with normal level of FSH and LH, but there is decrease in the estrogen level. And resistant ovary syndrome, the biological appearance of the ovary are normal with abundant primordial follicle. Next is the hormonal changes in menopause. So the diagnosis of menopause is usually clinical. The first endocrine change is the PAL and inhibin level, which prevent the release of FSH. So when the inhibin level decreases, there will be compensatory increase in the FSH level above the premenopausal state, and the rise in LH level also occur, but it occur later after FSH level increases. And before menopause, the estrogen source is ovaries that are released from the granulosa cell of the ovary, and the progesterone is released from corpus luteum, and the level of GnRH hormone, they fluctuate with the menstrual cycle. After menopause, the estrogen is formed by the peripheral conversion of adrenal androstenedione to estrone, whereas the progesterone is formed from the peripheral aromatization of the adrenal steroids. And after menopause, the level of GnRH hormone are persistently elevated. So in menopause, there is initially fall in the inhibin level, and there will be a compensatory increase in the FSH level, and after FSH, there will be also a rise in the LH level occur, and the level of GnRH hormone will also be elevated. So in the perimenopause and postmenopause, initially the GnRH level increase in pulsatility in perimenopausal period, but it then progressively decline in the postmenopausal period. Similarly, the FSH and LH level are increased in the perimenopause state, and postmenopausal women, initially FSH and LH level are raised, but then they decreases progressively, and the estrogen, progesterone, inhibin, and the testosterone level all decreases in the post menopausal women. Next is the symptoms in a postmenopausal woman. So in menopause, there will be immediate symptoms occur, intermediate symptoms occur, and delayed symptoms. And the immediate symptoms, initially we have vasomotor symptoms, which are most common. And the vasomotor symptoms include hot flushes, which are a classical vasomotor symptom. And hot flushes, when occur at night time, they are called as night sweats, and they occur in about 80% of the women. and the heart flushes occur because of disturbance of thermoregulatory center, that is the hypothalamus, and it occur is a consequence of vascular response to the change in the thermoregulatory center. And the heart flushes which occur at night time, it causes the awakening of the female from sleep, and hence will affect the quality and the quantity of the sleep. And the factors that are associated with the increasing worsening of the symptoms, that is the heart flushes, are female who consume alcohol, who do smoking, caffeine consumption, and a high BMI level. Next one is the psychological symptoms. So psychological symptoms are also the immediate symptoms, and they occur in a menopausal lady, and they include the mood swings, irritability, depressed mood, anxiety, lethargy, fatigue, changes in the memory and cognitive function. Second one is the intermediate symptoms that occur from 3 to 10 years, and intermediate symptoms include sexual dysfunction. So sexual problem are common in the menopause, and that include loss of sexual desire, loss of sexual arousal, problem with the orgasm, and there is sexual pain, which is known as dyspnea. And there is also urogenital atrophy occur in the menopausal lady, and urogenital atrophy occur because of estrogen deficiency, and urogenital atrophy, the staining of the urea occur, vaginal dryness occur, etching occur, urinary symptoms like urinary frequency, urgency, and nocturia occur, and there is increasing risk of the infection. Third one is the delay symptoms that occur after more than 10 years of menopause. First one is the cardiovascular diseases. So in menopausal lady, there is increasing risk of MI and the stroke. And the risk of MI and stroke increases because of the decrease in the estrogen level, because the estrogen is associated with the maintenance of the lipid profile. So an estrogen deficiency, there will be disturbance in the lipid profile occur, like there will be elevation of total cholesterol occur, there will be decrease in the high density lipoprotein, which are the good cholesterol, and there will be increase in the LDL, which is known as the bad cholesterol, whereas the triglyceride level remain normal. So due to the deficiency of estrogen, the LDL level will rise and the HDL level will decrease, which increases the risk of stroke and MI due to atherogenesis or atherosclerosis. And there will be also symptoms of the skeletal system, because in estrogen deficiency there will be increase in the bone turn means that there will be increase in the bone resorption and decrease in the bone formation, and hence it will lead to the increasing risk of the fracture of trabecular bone. And the common sites and wall in the fracture are hip joints and the vertebra. And usually a skeleton is composed of two types of bone, the compact bone and the trabecular bone. The compact bone make up about 80% of the skeleton, and it is insensitive to the estrogen, whereas the trabecular bone that made up constitute 20% of the skeletal bone, and it is highly sensitive to the estrogen and more prone to the resorption after menopause. So in menopause, there is increasing risk of fracture that are made of the trabecular bone. Next is the management of the menopause. So initially, we advise the patient conservative treatment that include the lifestyle modification and dietary changes like cessation of the smoking, reduction of the alcohol consumption, take care of the diet, do regular exercise, and maintain a normal BMI. The second one is non-hormonal approaches. The non-hormonal approaches include complementary therapy like acupuncture, which is a traditional Chinese method where the needle are inserted into specific points on the body. We also advise hypnotics, and we also advise certain herbal therapies, and the non-hormonal therapies for the control of vasomotor symptoms include alpha adrenergic agonists, that is clonidine, beta blockers like propranolol, selective serotonin reuptake inhibitors like fluoxetine and paroxetine, and the GABA analogs like gabapentin. They are all associated with controlling the vasomotor symptoms. Third one is the hormone replacement therapy. So HRT is the mainstay of treatment of the menopausal symptoms, and the HRT involve the use of one or more group of medication that are designed to artificially boost the estrogen and progesterone level and relieve the menopausal symptoms. And the HRT can be given either systemically for the control of vasomotor symptoms and osteoporosis, it can be also given locally for the control of local symptoms, that is the vaginal dryness. And the HRT may either contain estrogen only. So the HRT containing estrogen is advised in the woman who had undergone hysterectomy before, because there is no risk of the endometrial stimulation and subsequent hyperplasia. So a woman who had undergone hysterectomy before, we give HRT that contain estrogen only. Second one is the HRT containing the estrogen and progesterone. They are advised in the postmenopausal women, and they include both estrogen and progesterone. And the progesterone is used to prevent the endometrium from the continuous stimulation of the estrogen stimulation, and prevent the endometrial hyperplasia. And premenopausal women, we give estrogen and the cyclical progestrogen and the HRT. Whereas in postmenopausal women that are more than 54 years of age, we give continuous estrogen and progesterone. So now let's talk about the properties of the estrogen and progestogen. So the estrogen used in the HRT is estradiol, which is the main physiological form of the estrogen, and the HRT may also include estrogen in the form of estrone and estriol. And the progestogen, they are structurally different from the progesterone. And the progestogen that are used in the HRT include medroxyprogesterone, levonorgestrel, norethindrone, and micronized progesterone. And the regime used in the HRT, they either include the continuous HRT that include estrogen and progesterone that are given continuously, and the cyclical HRT, which is given over 28-day cycle with a 16 to 18 days of estrogen alone, and then followed by 10 to 12 days of estrogen along with the progesterone. So the HRT is either given as a continuous HRT or the cyclical HRT. Now let's talk about the route of administration of the HRT. So the HRT, hormone, that is hormone replacement therapy, they can be given orally, which is the most common route, and they maintain the estradiol, which is physiological estrogen to estrone ratio of 1:2, which is the reverse of the normal physiological ratio. And all estrogen are taken once daily, and they are cheap, and they are usually well tolerated. And oral route usually involve the past effect, the past metabolism in the liver, and therefore it will interfere with the metabolism of other drug, and similarly it also affect the lipid metabolism and the coagulation system. Second one is the transdermal route. The transdermal route contain the estradiol to estrone ratio of 2:1, and this ratio is highly physiological. That is similar to the premenopausal state, and this route also avoid the past impact of past metabolism of the liver. And this route is a particular use in the older patient, where continuous or gradual buildup estrogen is required to avoid the adverse side effects, and they are usually given in case of the osteoporosis. And the third one is the vaginal route. So it is a local route, and it is used for the treatment of the local symptom. And this route is suitable for the women whose symptoms are of the genital origin, and those ladies, the systemic route is contraindicated. For example, in a patient who have a past history of breast cancer, we cannot give the HRT to a systemic route. Therefore, we give it locally for the control of the local symptom. Next one is the side effects of the HRT. As the HRT include both estrogen and progesterone, so the estrogenic side effects include breast tenderness, nausea, dyspepsia, headache, and leg cramps. And similarly, the estrogen also increases the risk of thromboembolism, and estrogen increases both the risk of venous thromboembolism and the arterial thromboembolism. And the progesteronic side effects include fluid retention, breast tenderness, that is mastalgia, headache, mood swing, bloating, and acne. Next is the indication of HRT. So HRT are advised to the menopausal lady if she had a vasomotor symptoms, which is the first indication and the principal indication of the HRT. And significant improvement is seen in 90% of the cases within 6 weeks of using HRT. Similarly, it is also advised in case of the skeletal symptoms, like women who had decrease in the bone mass density. In such a patient, HRT is advised to prevent the osteoporosis and decreases the risk of fracture. And HRT is strongly indicated in women who had premature ovarian failure. And HRT is also indicated in a female who have genitourinary symptoms, because HRT decreases the vaginal dryness, irritation, and dyspareunia. Similarly, it also improves the symptoms of cystitis and dysuria. And there is no role of HRT in treatment of incontinence. HRT is also advised in case of the cardiovascular system symptoms, because HRT has a protective effect on the cardiovascular symptoms if started early during the menopause, because the HRT there decreases the risk of the stroke, and similarly HRT also reduces the risk of ischemic heart diseases. And next is the colonic cancer. So HRT use is associated with a reduction in the mortality of the colonic cancer. However, HRT is not indicated for the protection of the malignancy. Next one is the contraindication of the HRT. First one is the absolute contraindications that include the presence of suspected chances of pregnancy, patient having breast cancer, endometrial cancer, or having active liver disease, patient having uncontrolled hypertension, who had a confirmed current history of venous thromboembolism, or patient having coagulation disorder like thrombophilia. And the relative contraindications include presence of a large uterine fibroids, past history of benign breast disease, unconfirmed venous thromboembolism, a patient having the chronic and stable liver disease, a patient having migraine with AVA, and such patient HRT is contraindicated. And the side effects of HRT include return of menstruation in the postmenopausal woman. There may be premenstrual syndrome symptoms occur, increasing risk of thromboembolism. There is increasing risk of endometrial breast and ovarian cancer, and there is also disturbance in the lipid metabolism occur. At the end, let's talk briefly about the postmenopausal bleed, which is the bleeding after 1 year of menopause, and it is also defined as the bleeding from the genital tract after 12 months of amenorrhea in a postmenopausal woman. And the causes of postmenopausal bleeding include endometrial hyperplasia, atopic endometrium, which is the most common cause of postmenopausal bleeding, and the infections like cervicitis, vaginitis may causes bleeding. Similarly, a carcinoma like endometrial carcinoma, cervical cancer, and ovarian cancer, they also cause postmenopausal bleeding. The fibroids, polyps, bleeding disorder, gut pessaries, and IUCD, they may causes postmenopausal bleed. And similarly, postmenopausal bleed also occur in case of trauma like that occur in intercourse. Next is the management of the postmenopausal bleed. So initially we will take a detailed history in which we ask about age, number of episodes of bleed, the amount of bleeding, the duration of the bleed, and family history of carcinoma. There is any history of bleeding disorder in the family. And examination, initially we do general physical examination, then abdomen and pelvic examination, and similarly we also do past speculum examination. And investigation, we do CBC, coagulation profile. We also do the pelvic ultrasound and the abdominal ultrasound, and similarly we also take endometrial biopsy. And the treatment postmenopausal bleed depends upon the cause. If there is infection, we give the patient antibiotic. In case of carcinoma, we do total abdominal hysterectomy and bilateral salpingo-operectomy. And in case of pessaries, IUCD, we remove the pessary IUCD. So it was all about the menopause and postmenopausal bleeding.